30 seconds and then we'll start. But I think the participant is on Zoom, and I think if we are able to hear each other, I think all right, we're live. Good evening, everyone. Welcome to today's webinar brought to you by IASO Academics. The event that we have today is Mastery of Surgery. We do these events once every fortnight. So 2 weeks back, we had ISO Masterclass, which was on management of early breast cancer. And today will be Mastery of Surgery, where we discuss surgical planning in form of radiology and then few surgical tutorials. I welcome all the faculty and the participants today, and I invite ISO Secretary, Dr. Narendra Hulikal, for the welcome address. Sir.
Thanks, Vijan. Good evening, everyone. So, one greeting from the Indian Association of Surgical Oncology. It gives me immense pleasure to welcome you all for our one of the flagship academic events, that is Mastery of Surgery, which is 10th in the current series. And this program has been conceptualized to bridge the gap between theory and practice by focusing on step-by-step surgical techniques, decision-making in complex and oncological situations, and getting operative insights from the experienced faculty. And definitely this program has been popular thanks to the work of Dr. Srijan and Dr. Ziba under Dr. T.S. Rao, who is president of IASO, and the Basutarakam Indo-American Cancer Center. And this is one of the, as I said, it's a flagship program imparting high quality education and really contributing to capacity building among the residents as well as the young surgeons. I encourage all participants to participate actively, not only passively listening to the lectures. And whatever doubts, please post your questions to the faculty. And also later also you can give your feedback regarding academic programs, how they are doing, what you exactly want, what topics you want. All this can be, you can give a feedback to Dr. Srijan, who will communicate to us, and the leadership will take appropriate decision. And also, I hope all of you are members. If anybody is not a ISO member, please become a member. We have an upcoming event in Lucknow in October. We are celebrating Golden Jubilee. So I welcome you all to present abstracts and to again participate actively. Again, once again, thank you all and welcome all of you. And also, we have esteemed faculty today, Dr. Jyoti Arora, Dr. Amar Deshpande will be joining in a bit of time, and Dr. Kushal. So welcome all of them. Thank you. Over to Srijan. Thank you.
Thank you, sir. So we have 3 talks for today. The first one is by Dr. Jyoti Arora, who's a consultant radiologist at Apollo Hospital, New Delhi. She's an expert in breast imaging and interventions, a pioneer in MRI-guided vacuum-assisted breast biopsy and scarless removal of benign breast lumps. What we've requested today her to speak on is MRI breast for surgeons. We invite you to this program, madam, and we invite you to share your screen and begin your talk. I'll invite the other participants to kindly post their queries to Dr. Jyoti in the chat box and Q&A, and we'll take up those questions immediately after her talk. Thank you.
Thank you for giving me this platform. Is my screen visible?
Yes.
Okay. So the topic for today is breast MRI for the surgeons. I'll try my level best to simplify this complex topic as much as possible, but please feel free to ask any questions that you have at the end of my talk. So breast MR, it's very important to know why it has been ordered. The indications can be varied, and a lot of time our interpretation of the same findings that we see on the MR depend on what was the initial indication for which the scan has been done. So it can be a screening MR. It can be the most common indication these days is preoperative evaluation to see the extent of the disease, post neoadjuvant chemotherapy to see the response, post positive surgical margins post lumpectomy. So many a times initial imaging is not done, and a patient comes directly after lumpectomy without any initial imaging. So we then directly do an MR to see if the margins are positive or not. Metastatic axillary lymphadenopathy in an unknown primary, or when there is a Paget's disease suspected because there might be underlying DCS or IDC. Whenever we have equivocal mammographic findings as a problem-solving tool and to see for the implant integrity. So when we compare the MR to the rest of the modalities like mammography or ultrasound, it is the most sensitive tool. And with newer sequences, the specificity, which it was considered to be lower in the initial days, and with the experience of the breast radiologist, the specificity is now significantly has improved to an extent that, that is becoming, even for screening MR in the dense breast, this is becoming a prime modality because of its increased specificity with the newer sequences. So coming to the protocol, what we need to identify is what is a T1 weighted sequence, what is a T2 weighted sequence, and many a times we also do or may just do a T2 fat sat sequence. Then dynamic T1 pre and post contrast. When we do post contrast, it is usually a dynamic sequence. That is, after giving the contrast, we would take multiple sequences after the contrast injection. But always remember the contrast should be injected with a power injector and not with a handheld injector. The MR should be at least 1.5 Tesla or more, and it should always be done in a breast coil. A few centers do it in a prone position by putting some pillows. So the whole concept of doing MR in breast coil is not just so that the breasts are hanging, but the coil has multiple channels in it, which increase the resolution of the MRI. And the other important sequence is a diffusion weighted sequence. Now, this is a T1 weighted. If you get confused between T1 and T2, always here the images have been cropped. But otherwise, if you see the spine, the fluid around the spine, if it is black, then it's a T1. But if the fluid is white, then it's a T2 weighted sequence or a modification of a T2 weighted sequence. So always remember between T1 and T2, T1, any water signal would be seen as black, whereas in T2 it will be seen as hyper. Positioning is very important because a lot of time, if it is not proper, as you can see here, the signal would not be great, and as a result, it would lead to loss of signal and loss of clarity. Here, as you can see, half the breast is outside the coil. So the coil, the dent of the coil is at this place. So half the coil is, half the breast is outside the coil, and a small lesion outside the coil will get, the signal would not be great there. Moreover, because of the distorted breast, it might appear as if the nipple is retracted or a skin is retracted. So same patient, now you can see the position. Both the nipples are really pointing downwards, and you can see the size is more or less same. Now, why, when I said we do a post-contrast T1 SAT sequences, why fat suppression is important? Because fat on both T1 and T2 appear white. So this is all fat. And if we give contrast, that also appears white. So anything which is enhancing will not be visible or would be masked because of the fat. So when we give contrast, we always suppress the background fat. So now this enhancing lesion, which was here, which was not visible on without a fat suppressed sequence, now it is seen very beautifully here. It is standing out. So always remember, it has to be a good fat suppression, and that is the reason why we say that it should be at least 1.5 Tesla or more. If the MR quality is not that great or not that high strength, then the fat suppression doesn't come out well. Inhomogeneous fat suppression means a lot of artifacts. The first thing that we see is the fibroglandular tissue, which we see on the T1 weighted sequence, which tell you how much the amount of the breast tissue. So it corresponds to the density seen on the mammogram. So it is either fatty, scattered fibroglandular tissue, heterogeneously dense, or extremely dense, the same way as we have on the mammogram. But this density does not affect the quality of the MR as it does in the case of mammogram. So a lot of times it's an extremely dense breast, but we can pick up cancer even as small as say 5 or 6 millimeter very confidently, because the background enhancement is minimal. So it's the background enhancement which can be minimal, mild, moderate, marked, which affect the sensitivity of the breast MR. So here you can see this is a fatty breast, scattered fibroglandular tissue. Here it is heterogeneously dense, and this is extremely dense. And here we have the post-contrast fat suppressed images, which tell us whether the enhancement is minimal, mild, moderate, or extreme. So obviously, when you read when a moderate or marked background enhancement means that the sensitivity of the MRI would be a little compromised. So the first, after seeing and having it in mind how sensitive this MR would be, the next important sequence that come is a T1 fat sat subtracted images, and we make a MIP of it. So what we get is a 3D data, and we convert that into a 2D image like this, which is called MIP. So this gives you a very good impression of what exactly is happening. For example, in this case, this was a biopsy-proven case of left breast cancer. We know the right breast is completely clear. But on the left side, it was not just one. There were multiple lesions. The masses are irregular in shape. You can see how many of these are there. And then they are also causing nipple retraction. So all this information can come from the very first image that we see, which gives you an overview for your, even for your surgical planning. It gives you a very good overview. This is the MIP T1 FATSAT post-contrast images. The same image, we can even do it, reformat it in coronal and SACH. So when we do it in a coronal, as you can see here, from here you can, this is 12 o'clock, this is 6, this is 3 o'clock, and this is 9. So the abnormality is between 3 to 6. So if you have to remove, if really patient wants a breast conserving surgery, then you need to put one marker here and the other here. You can do bracketing clips and followed by bracketing wires post NACT. If it is a very good response, you can still give a conservative surgery to the patient, because the rest of the quadrants are completely clear. And this SACH MIP gives you whether this abnormality is going right up to the nipple, because that will again give you, help you in your surgical planning, that whether the nipple needs to be excised or sacrificed, or you can save the nipple. Even if you're doing a mastectomy, whether a nipple sparing mastectomy can be done or not. The other important thing that you always need to remember is that always see the pre-contrast T1 FATSAT sequences. So this is a T1 FATSAT, that is fat suppressed. Pre-contrast, that is, you can see there is no contrast in the heart. If there is this white hyperintensity, if there is this bright signal here, that means the ducts are filled with either proteinaceous debris or hemorrhagic contents. It is very important, because if you just go on T1 FATSAT's post-contrast images, then you may think this is all abnormal tissue. This is not abnormal. This was all there on the pre-contrast images. That's the reason why we go for subtracted images. So I told you the MIP has to be created from the subtracted images, because if there is any contrast, any bright signal on the pre-contrast that needs to be subtracted. So we subtracted from here this signal. So here you can see there is no enhancement. So it's always the subtracted images which will tell you the true enhancement. If you just go for T1 fat set post contrast, you may see extra signal which was already present even before giving the contrast. So from this, the very important conclusion that you draw from the breast MR is that it has a very, very high negative predictive value, which is 99%. And this gives us the confidence that if the breast MR for the contralateral breast is negative, you can be nearly sure that there is no invasive malignancy in that breast. And even at times when we see multifocal disease, but it is limited to one segment, you can still think of giving a breast. You can do a wedge quadrantectomy because the rest of the quadrants are are clear. That means the chances of any cancer sitting in the rest of the quadrants is almost less than 1%. But remember, not all enhancing lesion on MRI are cancers. So we need to characterize the lesion before we change our management. So any new lesion that you see that was not visible on ultrasound or on the mammogram, it does not automatically means that it is also cancer and you need to change your management accordingly. So coming to lesion characterization, you need to know artifacts. That is, you should know if the positioning is good, whether the fat suppression is good. And many a times you also have to keep in mind that the background enhancement was lot or it's a minimal enhancement, because that can also affect your clinical decision. Size of the lesion, location that we have seen, we can see from o'clock position, the distance from the nipple, chest wall, and skill. And then we come to the characterization of the abnormality, whether it's a focus, it's a mass, or a non-mass enhancement. So whenever we see a mass, we talk about its shape, the type of enhancement, its size, its distance from the nipple, from the skin, and from the chest wall. So lesion type, it can be a mass, a small focus, which will be, a small area of enhancement where you cannot tell whether this is a proper a 3D SOL or a mass, or whether it's a non-mass enhancement. That means there is no abnormality seen on the pre-contrast images, and this area is seen directly on post-contrast images, and it does not have a shape or a space occupying lesion. It is not seen as a space occupying lesion. So when there is a proper mass, what all do you see? You see its shape. For example, this is a oval shape, but the rest of them are irregular. Whether the margins are circumscribed, again, this is circumscribed, but the rest of the three show non-circumscribed margins, that is irregular. Here you can see some speculations are there, and internal enhancement pattern. So if it is a homogeneous enhancement, it is likely to be benign. If it is circumscribed, again, it's likely to be benign. And if it is an oval shape, again, the chances of this are likely to be benign. So this mass is likely to be benign because it's oval, it is circumscribed, and it has homogeneous enhancement. But if the lesions are irregular in shape, they have non-circumscribed margins like speculation, and internal heterogeneous enhancement is there, or the enhancement is rim-like. So here you can see this is a rim pattern of enhancement. Then these are likely to be cancerous, or these are at least suspicious. You'll give them a BI-RADS 4 or a 5 depending on the other findings. An example of irregular margin, here you can see the margins are not circumscribed, and this is an example of speculate lesion. This is internal, dark internal septae. It is a very typical sign for fibroadenoma. If we see this sign, we are pretty confident that this is likely to be a benign etiology. Now coming to focus, it's a tiny dot of enhancement that does not clearly represent a space occupying lesion or a mass, and does not show clearly correlate on the pre-contrast imaging. Now focus, it can be anything right from completely benign findings like intramammary node to papillomas to a small IDC. It can be anything, and we tend to give our impression on imaging on the basis of clinical indication, especially in when it comes to focus. One is kinetics, and the other thing is that we would always keep in mind the indication for which the MR is being done. Now, this patient had multifocal multicentric disease on the right side, but this was a small little focus that was seen on the contralateral side. So this was definitely suspicious, and although it's a small focus, but keeping in mind what we are finding on the other side, this becomes suspicious. This is another case. This patient had a bloody nipple discharge. So here you can see a small little focus of enhancement, which is along the duct. So this, because the indication is bloody nipple discharge, so I would give it like and the location is intraductal, I would call it that this is a small papilloma and give it a BI-RADS 4A. Coming to non-mass enhancement, now non-mass enhancement can be focal, they can be linear, they can be segmental. When I say segmental, it is a triangular area of non-mass enhancement with its apex towards the nipple. Then it can be a regional area of enhancement, and linear is generally along the ducts, but it is along a line that the enhancement is seen. Out of these, it's the segmental and the linear. Whenever when you read the reports and read words like segmental area of non-mass enhancement or linear area of enhancement, they become suspicious. So if it is segmental clustered ring pattern, we would at least give it a BI-RADS 4B. And if I see microcalcifications on the mammogram, then it's very definite that this is DCIS. I would upgrade to 4C. Internal non-mass enhancement patterns can be homogeneous, heterogeneous. This is an example of clumped enhancement. And this here, you can see there are multiple tiny little rings. So this is a clustered ring pattern. And as I said earlier also, this is very suspicious for DCIS because it's the enhancement along the ducts. Although in India, I would always keep in mind granulomatous mastitis because that can also give us similar appearance. Then I would go to the mammogram. If I can see microcalc, I would more towards DCIS. If the patient is giving me history of bloody nipple discharge, again, I would think more in terms of DCIS. But if patient has signs of infection, then I would be thinking about periductal mastitis. So this patient had a very small area of microcalcification, as you can see here. But and this was proven to be high-grade DCIS. And when the MR was done, you can see that tiny little dot of microcalcifications that we were seeing on the mammogram is actually only tip of the iceberg. And here you can see a lot of non-calcified DCIS. So whole, the upper and the lower outer quadrants were filled with DCIS. So it's very important to do an MR. Generally the impression is that if it is masses or bigger lesions, then we go for MR. But if it is a DCIS, then people generally think that DCIS, MR is not that sensitive. MR is highly sensitive for high-grade DCIS. Yes, for low-grade DCIS, it may not show any enhancement. So if we do a biopsy, if the biopsy shows high-grade DCIS, we always do an MR because many a times what we see on the mammogram is just the tip of the iceberg. Then the next thing in our analysis that we do is the kinetic analysis. So this is a pre-contrast image. The early post-contrast, as I said, we take multiple sequences after giving the contrast. So this is early post-contrast, and you can see the whole area is very bright, or it is enhancing very intensely. But on the delayed post-contrast, you can see there is washout of the contrast. So if we put our ROI, they will show us this type 3 patterns, which is highly suspicious for malignancy. This is an example of persistent curve where the enhancement pattern is just going above and there is no washout of the contrast. And then the third pattern is type 2, where after initial rise, there is a plateau in the second half of the kinetic analysis. Now, along with the main cancer that we have just, or the main masses that we have seen, you might find associated findings which help us in our decision whether the lesion is likely to be benign or malignant. For example, if the mass is associated with distortion, chances of malignancy become high. If there is skin or nipple retraction or invasion, then again the chances of malignancy are high. We always look at intramammary lymph node because the cancer might go and cause enlargement of the intramammary node. So it's important to identify it's an intramammary node or a satellite nodule, or whether even if it is a node, whether it's normal size or abnormal. Chest wall invasion, again, suspicion goes obviously towards malignancy, axillary lymph nodes, and many a times on the MR itself, you may see bone, lung, or mediastinal nodes, and at times we have even picked up liver metastases. So here you can see this is the main mass, but you can see the spicules, which is causing skin retraction. So on the coronal, the skin retraction is seen quite well. So this is the enhancing lesion, and you can see the spicule going up till the skin. Here you can see the mass is involving the chest wall. So this is the chest wall muscle which is involved. And here you can see there is a lung metastatic deposit. So here you can see there is a metastatic lesion that was picked up on the MR. Now, so all this we were talking about T1, which is the most important sequence, especially the post-contrast T1 fat-sat sequences. The other important sequence is T2 because that helps us in making a decision whether the lesion is likely to be benign or malignant. If there is hyperintensity, that means there is a bright signal there, chances of the lesion being benign are high, and they are likely to represent things like cyst, myxoid fibroadenomas, or lymph nodes. But at times, if it is a known case of cancer, they're usually seen as dark, but if they are seen as bright, it could be because of internal necrosis or because there is mucin present in those cancers, or a liposarcoma can also appear bright. So here, T2 hyperintensity. So here you can see there is hyperintensity, and this is a small intramammary lymph node. It is always seen along the vessel, so that is a very good sign. This is a myxoid fibroadenoma. This is again T2 bright. So I'll just show a few cases of different BI-RADS. This is a completely normal, so there is no abnormal enhancement. It's BI-RADS 1. This was an interesting case. This patient came with this appearing as spiculate lesion. On the ultrasound, there was a cystic lesion with a small hyperechogenicity there. So when we did an MR, this was actually fat suppressed on fat saturated sequences. So on detailed history, she gave a history of surgery at this site few years back. So it was actually fat necrosis at the scar site. This is a case of mucinous carcinoma. So here you can see this is a T2 weighted sequence, and it's very bright because it's all filled with mucin. Now, BI-RADS 3, we give it whenever the chances of malignancy are less than 2%. And the scenarios where we give BI-RADS 3 is when we have an asymmetric background parenchymal enhancement, a small focus of enhancement, but there is no history that could give us an answer what could be the reason for this focus. Masses which have all the benign features, but they're enhancing, we would give it a 3 until they become stable for 2 to 3 years. Then we downgrade them to 2. And non-mass enhancement when there are few T2 hyperintense cysts, so we know it's likely to be fibrocystic mastopathy. So here, this is a focal area of non-mass enhancement, but we could see T2 hyperintensity cyst in this area. So this was given a BI-RADS 3. This is a fibroadenoma, again an example of BI-RADS 3. This is an example. So here you can see this is asymmetric background enhancement. So this was given BI-RADS 3 again. A small focus of enhancement. No history that could suggest what could be the reason for it. So it was put on follow-up. So coming to BI-RADS 4 lesion, so this mass is showing heterogeneous enhancement and has slightly irregular margins. It can be a fibroadenoma, but obviously in a postmenopausal females, we would like to do a biopsy for this. So it was given a BI-RADS 4. It had type 3 curve, so that's the reason why it was considered suspicious. This lady had a biopsy-proven axillary lymph nodes, positive lymph nodes. And when the MR was done, we could just see few foci which were grouped together. So this was given again a BI-RADS 4. And coming to BI-RADS 5, that is the chances of malignancy are very, very high. And there is no single MR descriptor that, if you see that, you will call it BI-RADS 5. It's usually a combination of features that help us and give us our suspicion of BI-RADS 5. So here you can see irregular shape, heterogeneous enhancement. It is showing diffusion restriction. That is a very important sign that help us to differentiate between benign and malignant. And it was also giving us type 3 curve. So all these features together, we came to the conclusion of BI-RADS 5. Here, this patient had axillary lymph nodes and irregular mass with peripheral rim enhancement. So this was a case of BI-RADS 5. This is again BI-RADS 5. It has all the multiple features which will help us to get our conclusion to BI-RADS 5. Dense breast, just showing a couple of cases to show how MR help in preoperative diagnosis or staging of the cancer. So this patient had this left breast mass that you can see in the upper half. But it was a very dense breast, so MR was decided. And here you can see the main mass that was biopsy proven. But on the opposite side, this is a unique lesion that is standing above. There is a lot of background enhancement, but this is standing above that background enhancement. So this was also suspicious. We did an ultrasound, found the lesion on second look ultrasound, biopsy proven to be cancer, and ultimately we did a conservative surgery on this side. Another patient came for screening. There was a very little focal asymmetry that you can see it here, not present on the opposite side. So I called her back for this focal asymmetry. On the ultrasound, I could see this area of focal shadowing, echo poor lesion in the axillary tail, but as well as in the axilla where I could see it on the mammograms. So both these lesions were biopsied and they were proved to be invasive lobular. So we did an MR because it was invasive lobular as well as it was a dense breast. So what we saw, the whole segment was enhancing. It was not just two lesions, but the areas in between going right up till the nipple, the whole area was abnormal. But in addition to that, the opposite side also showed non-mass enhancement. This we could not see on ultrasound, so we did an MR guided biopsy, and the histopathology came back as bilateral lobular carcinoma. So how MR helps change our management, but we should not change the management until we prove that it's a cancer. So in conclusion, contrast enhanced breast MRI, it's a valuable adjunct to mammography and ultrasound because it has a very high sensitivity to invasive cancer. It gives us multiplanar imaging and morphological and dynamic imaging with the newer sequences like diffusion weighted increase the specificity of the MR. Because the benign breast processes would also enhance and the normal tissue also enhance. So that is one of its limitations. So we need to do a biopsy before we change our management. So triple assessment is must, and always remember MRI is not a substitute for histological diagnosis. I see a lot of times patient has an area of microcalcification and patients are subjected to MR just to see whether that area is enhancing or not. Even if it is not enhancing, we still need to do a biopsy because it can be low-grade DCIS. So it's not a substitute for histological diagnosis. And in the end, once the histopathology, you get the histopathology, it's very important to have a concordance, because many a times I've seen radiologists would do a second look ultrasound. They feel that lesion is the same as what we are seeing on the MR. They do a biopsy, they get a benign. So at that time, it's very important to do a concordance, whether the MR findings, if they are very suspicious and you're getting a benign on because it has been done as an ultrasound guided, and it may not be actually a concordant lesion. So a rat path concordance should be established before giving a green signal to the patient. Thank you.
Thank you, Dr. Arora. You delivered beautifully on the mandate that we asked you to explain to the surgeons the basics of MRI and the various sequences and how we utilize them. I just take one question first from the chat box, which is, do all young breast cancer need MRI?
So see, with young breast cancers, it's likely that their mammograms would be dense. So they would definitely need would need a MR, especially to see the extent of the disease, so that you can, if whether a breast conserving surgery can be done for or not. And even if we are thinking multifocal disease, many a times what happens is whether the disease is going up till the nipple or not. I have picked up very tiny lesions on the skin itself, which and then I tell my surgeons that you are taking the patient for mastectomy, but don't do a skin sparing mastectomy. And obviously, we do need to screen the opposite side because they are young patients, so their risk of cancer is high. So contralateral side needs to be screened.
I think the next question is, I think, which type of curve indicates malignancy on MR?
So
I think you did tell us about the curves, but yeah, if you could repeat that.
So if it is type 3, the chances of malignancy are very, very high. It's about like more than 80%, but majority of the times we see it's the type 2 curve. So even if you're getting type 2, you cannot ignore them. Low-grade malignancy, mucinous cancers, all these kind of cancers, your ER/PR positives, because they are not that high aggressive ones, so they are more likely to give you type 2. So, but if you get a type 3, you just can't ignore them. That has a very high chance of being malignant.
Perfect. The next one is, could you please explain again about inhomogeneous artifacts on fat suppression MR?
So this is again, I see it very often when the MRs come to me for review. One, because they're not positioned properly. So what happens is the breast is touching the coil, and as a result, the areas where the breast is touching the coil, the fat suppression is not homogeneous. That means the whole of the breast will become black because there is fat, but the area where it is touching the coil, because maybe it's a big because the patient is not positioned properly, that area will remain white. So once it remains white, you don't know whether this is because of inhomogeneous fat suppression or is it because of enhancement, because both of them appear white. So that's the reason a small lesion can be missed. And then if we don't have very like less than 1.5 Tesla, again, when we go for lower strength MRI, then fat is not suppressed. So fat is white, enhancement is also white. So we have to suppress fat, only then we can see the enhancing tissue.
All right. I think the next question we have is now this is about reading the MR. A more practical challenge we find is in interpreting MR in the OR. So in your practice, let's say, for example, you have a mass that you said, which is seen on MRI versus a non-mass enhancement. How do you help your surgeons navigate to such lesions in the OR? So I know you are not in the OR, but how do your MDT proceed in such situations?
So see, when we say a lesion is at 1 o'clock or a 2 o'clock, so when I say 1 o'clock or 2 o'clock, that means the left breast, it will come in the outer half. So when the patient, that's a prone position, but when in the OR, the patient will lie supine. So the breast will go outward. So the change in the position is much more if it is a bigger breast and a fatty or a wobbly breast. So what you are seeing on the MR, if it is a 1 o'clock, when the patient lies supine, it might fall to 2 o'clock. So that what we do is, after doing the MR, we go and do a second look ultrasound, and we tell our surgeons that although we are reporting on the MR at 1 o'clock, it's actually at 2 o'clock. So that difference your radiologist should be able to tell you, and that comes only with experience. So what we do is, we do, if it is a non-mass enhancement, and we have done a lot of these because now surgeons are going for oncoplasty, so they don't mind taking out bigger areas also because they can fill that gap with oncoplasty. So we would do bracketing wires. So if I see non-mass enhancement in the outer half, say from 2 o'clock to 4 o'clock, then I'll put 2 wires for them, one at 2 o'clock and one at 4 o'clock. And these wires can even be put on MR, under MR guidance. So we exactly, what we are seeing on the MR gets translated because there are wires. So they don't my surgeons won't have to worry about thinking if it is on the MR at this o'clock position, where would it be in the supine position. The other good thing that they can do, a lot of these patients would be having their PET CT. PET CT is done in supine position, so that correlates very well with the OR position. So having a look at the PET CT also helps.
Great. So I think thank you, Dr. Jyoti, for all these insights from you. There are a couple of more questions in the chat and the Q&A, so I just request you to go through them and
I'll reply
to them
on
there.
chat itself.
In interest of time, I think we'll move on to the next talk. Thank you so much for your talk today.
My pleasure.
We invite now our second speaker for today. We have with us Dr. Amar Deshpande. He's a consultant surgical oncologist in the breast unit at the Tata Memorial Hospital, Mumbai. And he'll be speaking about implant-based breast reconstruction. Welcome to our webinar, sir, and we request you to share your screen.
Sure. Can you hear me? Am I audible clearly?
Perfectly.
Okay, great. Okay, I'll share the screen. I don't know what's happened. This is not showing my screen. Would you be able to play it on your computer.
Yeah, just give us a moment.
Sorry about that.
No worries. Yeah.
Okay, so what I'm going to do is essentially speak about the implants and ADM reconstruction a little bit. And just one second. It's actually now allowing me to share my presentation.
You can go ahead. I think we have it here when we're able to see your full screen.
Oh. Yeah, you can see my presentation as well, right?
We are able to see our screen right now. Just give us a moment.
Okay. Okay.
Can you share your screen again once? We are not.
Yeah, I'll do that. Just one second. Oh.
Should we do it from our end again?
Yeah, I think it would be a better idea.
Great. We'll just do that. You just look at your Zoom screen and we're sharing from our end.
Sure. Okay, so the main thing I'm going to talk about is implant and ADM reconstruction, because that is how we are doing it at the moment. Yes, we are also using synthetic meshes, but synthetic meshes are doing the same work as the ADM. And ADM, essentially what it does is gives a better definition to the implant pocket as well as the inframammary crease. It also kind of buttresses the skin so that the weight of the implant is taken by the ADM plus the skin, and therefore the risk of implant extruding because of necrosis, skin necrosis, is less. ADM is basically a decellularized dermal matrix, which is derived from either animal dermis, or it can be a non-dermal one, which is from the submucosa or pericardium, bovine or porcine. Also in USA, they use even human cadaveric ADMs, which are not permitted in India or anywhere in the world. Can we go to the next slide, please? So I'm just going to present a couple of cases, and those are in the video. So the first one is a 38 years old who was the first one that I did in India after returning from the UK. And she basically presented with DCIS in her left breast. It was 6 centimeters, high-grade DCIS. She had an A-cup breast, so it was quite ideal for a direct-to-implant reconstruction. She underwent nipple-sparing mastectomy via inframammary crease incision, sentinel node biopsy, and immediate reconstruction with ADM and implant. Can we go to the next one, please? And the second case, which is immediately the videos are in together. So 66 years old, she had a low-grade DCIS 8 centimeters. This was screen detected. This patient had done in the UK. She underwent a skin-sparing mastectomy. The DCIS was quite close to the nipple, so we didn't save the nipple. And she underwent 2-stage prepectoral reconstruction. The first stage was with something called as Stratis, which is not available anymore. However, there are other meshes available, and you can use those for not Stratis. Sorry, I mean Surgiment. Surgiment is not available anymore because of high levels of endotoxins found. However, there are other flat meshes available which can be used for the similar purpose. She had subsequently had her expander changed to implant. I have just shown the expander and prepectoral flat mesh reconstruction here. So we can go to the next one, which is a video. So this lady is just having, this is the first one. just having the sentinel node biopsy. I'm not going to spend too much time in sentinel node biopsy. We'll just move on from there. The sentinel node biopsy is complete. In this lady, I had used blue dye for the sentinel node. So it was more of a sample, level 1 sample. And this is the intramammary crease incision that I'm using for the nipple sparing mastectomy. What I do is in the subcutaneous plane, I always infiltrate that with saline and adrenaline. Adrenaline used is 1 ml of 1 in 1000 adrenaline in 1 liter of saline. It's infiltrated in the right plane, which is the subcutaneous plane. If you are in the right plane, you won't find any resistance to the needle going in. And this is essentially to facilitate. So this is a hydrodissection. And I also avoid using cautery for the anterior flap dissection. This is to make sure that we are not jeopardizing the perfusion of the anterior flap. So I do this with the scissors, create some spaces, and then remaining Cooper's ligaments I just cut and take the breast out. That is for the anterior flap. Posteriorly, I don't mind using the diathermy. Once that anterior flap is done, I go to the posterior flap and just about the pectoralis major, just anterior to it, I would dissect and get that breast out. I take the fascia out if it is invasive cancer. This was a DCIS, so I have tried to save as much fascia as possible there. So the breast is out, and we are using something called as Braxon, which is the ADM available in India at the moment. So this is a pre-cut ADM, which you can use to reconstruct the breast outside the body. Flat meshes are generally used for subpectoral reconstruction. This is a prepectoral reconstruction. You can use 2 flat meshes to do a prepectoral reconstruction. However, that becomes very, very, very expensive. This is also very expensive. It costs the patients about 1.8 lakh at the moment, in addition to the charge of the implant and the surgery. So this has to be reconstructed. In the West now, Braxon Fast is available, which is like a clamshell. So you can actually reconstruct with 3 stitches only. However, here what you have to do is anterior surface, which is trifoliate, has to be reconstructed with either monocryl or PDS, whatever you prefer. And all those 3 parts have to be joined to form a concave surface, which will accommodate the convex anterior surface of the implant. You'll see in a minute how it does it. The posterior surface has got 2 windows. Those windows are for draining if there is any fluid that collects around the implant. Any fluid collecting around the implant is not really desirable, because that can get infected, and implant being a foreign body, it can attract the bacteria and get infected. We may lose the implants. Now, the implant is placed inside and will secure the implant in the pocket with 3 stitches. I put one at 12 o'clock, one at 9 o'clock, and one at 3 o'clock. Many people do it in many ways. I also, if the pocket is good enough and the implant is just sitting like a hand in a glove inside, I do not try to fix this inside. But if the pocket is slightly bigger, then it's better to fix the Braxon inside the pocket again at 3 o'clock, 12 o'clock, and 9 o'clock. That is to prevent the migration of the implant. So if you see, I'm just putting that stitch to secure the implant inside that pocket. So here you have to be extremely careful about the implant, because you're very close to the implant, and a tiny prick of the implant, and implant is ruined. Now, this last thing, the files got corrupted, so I have not been able to show you the final result of that. But this is another one that I had done in the UK, and you can see that I have already done the skin sparing mastectomy. That's the inframammary crease, and the muscle is exposed. Fascia is intact in most of the place because it was a 8 centimeters low grade DCIS. Wash is very, very, very important because it clears the debris from inside, and debris is the one that causes more seroma because of necrosis inside. It also unhurts the blood vessels which are bleeding, and you can control them, because bleeding is again, it can cause irritation, and that can lead to, first of all, infection, and secondly, capsular contracture later on. This is the surgiment that was available at that time. It was quite expandable. So what I'm doing is, because I'm using a flat mesh prepectorally, I'm just fixing it to the inframammary crease first with either PDS or I've used PDS here, 30 PDS. And you can even use monocryl, that's not a problem. Some people even use vicryl. I avoid using vicryl because being a braided material, it can again get infected. I don't know whether there is evidence of that. There may not be any, but I sleep better with monofilament material. Now, once that is done, if it is a direct to implant case, I would just put the implant under that and wrap this surgiment around, or the flat mesh around the implant. 2 flat meshes can be sutured together, and you can get the same kind of sheet which you can wrap around the implant. With the expander, what I've done is I've wrapped it around. I would inflate the expander to about 200 to 300 mils, and then wrap the surgiment around that expander. Drain is very important. My drain policy is that I keep the drain in until the drain is draining less than 20 mils in 24 hours. Once that is done, I take it out. I give antibiotics, oral antibiotics for a week. And on table, just before induction, I ask my anesthetist to give a single shot of Augmentin just before the induction, because that will take about the Augmentin that would be in the bloodstream before you actually give your first incision. You can see this expander has got a remote port which will be fixed on the chest wall, inferolateral to the breast, and from that port you will be inflating this implant every couple of weeks with about 100 mils of saline until the desired volume is reached. Okay, so that port is now fixed, and the space that is made around the port to get the port in the place at the kind of the junction of the tube and the port, the space is narrowed with a purse string so that that port doesn't migrate. So this is the result of the first stage. In second stage, that is just taken out and an expander is inserted, implant is inserted. So these are the 2 videos that I've shown. I'll take the questions now. I have got another presentation that I can do at some stage on how to optimize the results and give more information about the ADM and how the tips and tricks that have always worked for me. I've done about 780 something of these cases, and these tips and tricks, of course, I learned as I went along. However, I can share my experiences and help whoever is going to start with these to optimize their results. Thank you very much.
Thank you so much, Dr. Amar. Great presentation. And, part of this webinar after these videos is us asking you about those tips and tricks actually,
Sure.
instead of a presentation. So if you don't mind, what we'll ask you is some 3 or 4 pertinent questions that we generally have common for all these procedures.
Sure.
So the first one would be, do you have an algorithm for reconstruction where you prefer one over the other? And I would throw in autologous reconstruction as well here.
Sure.
Let's say this is mastectomy, something like a DF flap or something like that. We
Sure.
had so this is the second mastery of surgery we are doing on breast. So the last time I think we had the excellent faculty, Dr. Ashutosh Mishra, Dr. Shamsuddin. They spoke about oncoplasty and such. So what's your algorithm in reconstruction?
Okay, so first of all, we have to choose the patients right. Okay, so uncontrolled diabetics, heavy smokers, it's a no-no. Steroids, poor quality of skin, acne or sebaceous cysts or those kind of chronic inflammatory diseases on the skin of the breast, they can be a problem. Now, small breasts is where we should start with. So I started with A and B cup breasts and then built myself up to C and D as well. So I have done direct to implant reconstruction to up to about 700 cc's, and more than 700 cc's. I have always done a 2-stage reconstruction. Now the lady that you saw in the video, she had a 900 cc implant later on. She was quite big on the other side. She did not want to go down on the size. Otherwise, I had offered her reducing the breast and a reduction on the other side at the same time, but she didn't want to go down on the size. So these are the things that I always do. Also, you have to explain to the patients the problems that are associated with the implants and make that decision as well along with the patient. So shared care decision, a shared decision with the patients is what I always do. You asked something else as well. I forgot.
So choice between, I would say, implant-based versus autologous reconstruction.
Autologous. Okay. So some patients now, in my experience, what has happened is implant-based reconstruction has always been the simplest one for the patients to choose. So patient, when you tell them that this will take only 1.5 hours to do, as against LD, which takes about 3 hours in total. So they would always prefer to go for something which is simpler, quicker recovery, and where there are no morbidities at a donor site. So a lot of patients prefer. However, there are some patients who would say no to this because of the risks of capsulocontracture, the prospects of changing the implant in 10 to 15 years, and main thing now is anaplastic large cell lymphoma associated with breast implant. This happens 1 in 16,000 implants, according to the current figures. 1 in 16,000, quite rare in itself. However, the patients do not want that risk as well. So these patients go for autologous reconstructions. Now, where autologous reconstruction is planned, if LT will give you about 350 to 500 cc's of volume, depending upon the patient's size and habitus. But anything more than that, you would have to supplement it with either implant or fat. Fat transfer is something that I had started doing. So a lot of patients who wanted latissimus dorsi flap reconstructions were asking for that. However, some patients would go with the implant, but some patients, again, those who did not want the implant, chose to go for DFs or something different. Like I used to do tram flaps until 2017 as well. So those are the ones that were chosen as well by some patients.
I think one of the questions on the chat is, has age got to do with any of these choices? Do younger women prefer something over the older women and vice versa? What
I found is the younger women, they actually more commonly do not want reconstruction than wanting them. And I was very surprised. We had done a study that this was again in the UK. The younger the patient, they more accepting they were with just having a flat chest, even for on one side. However, there was no such preference about the implants. Those who had implants, they were happy to have them at any age. There was no difference whether the younger patients wanted implants or autologous reconstructions. Yes, there were a couple of athletes and couple of models that I had treated, and they did not want any scars anywhere else. They wanted nipple sparing mastectomy and something which is very simple, and they could get back to their running. One was a runner, and the other one was a gymnast, and they both wanted to get back to their activities quite quickly.
Perfect. I think the next thing we ask is what kind of learning curve trainees looking at before to have an idea about what they are embarking into. What would be the learning curve for these procedures?
Frankly, the learning curve is not very steep. The learning curve is actually at the stage of nipple sparing mastectomy rather than the reconstruction part itself. But what I would say is have a mentor, get a couple of cases done under supervision, and then go for it solo.
I think the next question asked is which of these implants are radiation compatible?
Unfortunately, the implants are not radiation compatible. What I mean by that is any implant, you are likely to get capsular contracture. Now, some implants like polyurethane coated implants, they are supposed to cause less capsular contracture. The smooth implants are supposed to cause more capsular contracture. Where smooth implants are, and in fact, the rate of capsular contracture is 25 to 30%. Textured implants, it comes down to about 10%. But what our radiation oncologists now do is they have some kind of planning where they do implant sparing radiotherapy. I'm not entirely sure whether that would mean that they won't get radiotherapy to chest wall or get less radiotherapy to chest wall, and if they in case have LVI or something, whether that would affect the ultimate overall survival or not. But this is something very new, and they are claiming that they will have less capsular contractures.
I think, and the last question we ask is, in the post-op care or the follow-up of these patients, what are the red herrings that you look for, which alarms you towards a potential grave problem?
Okay, so immediate post-op, sudden increase is hematoma, sudden increase in size or sudden swelling is hematoma with ecchymosis. Now, that needs to be immediately evacuated because, as we all know, blood is a very rich medium for bacteria to grow in. And longer you keep it there, more the chance of implant getting infected. Implant is a foreign body, and body is already in a mood to reject it. So we have to get it done as quickly as possible. Everything goes well, patient goes home. Seroma is another problem which can cause infections. So frequent reviews of the patients, and if there is any seroma, then get the radiologist to aspirate that under ultrasound guidance, because that seroma needs to come out. Of course, if you are aspirating the seroma, this should be done under strictest aseptic precautions.
Perfect. So thank you so much, Dr. Amar. I would request you to address some of the questions that we have not been able to cover, which are in the chat box and Q&A.
Sure.
In interest of time, I'll move on to the next talk. Thank you so much.
Sure. Thank you.
I invite our next speaker. We have with us Dr. Kushal Agrawal, and he's a consultant in surgical oncology at Aster International Institute of Oncology, Bangalore. His interests include robotic minimal access surgical oncology. And the topic that he'll be speaking on is a special case scenario, which is the surgery of internal mammary lymph node. And we invite him to share his screen and deliver his talk. Over to you, Kushal.
Yeah. Hi. Good evening, everybody. So just let me just start sharing. Can you see my slides?
Yes, not full screen yet. Yeah, go ahead.
Yeah. So before I start, at the outset, I would like to thank Dr. Rao sir, Dr. Shrajan, and Dr. Zeba for inviting me. I clearly remember 6 years back when I was a surgical oncology student myself when the IASO classes started, and for me personally, it's an honor to speak as a faculty in these classes. So thank you. The topic given to me today is a relatively controversial topic, which is essentially a domain of radiation oncologists, but we are speaking as surgical oncologists, and this is a surgical oncology classes. So I'll speak what is surgical consideration when it comes to internal mammary lymph node dissections. I'll be speaking briefly about anatomy, evidence, and indications and surgical considerations. So why should we surgically revisit the internal mammary lymph nodes? See, we have to agree to the fact that it is a second major regional nodal basin. Medial and central tumors preferentially drain into internal mammary lymph nodes. There are independent adverse prognostic factors. So, from abandonment to reconsideration, initially in the 1970s, the NSABP B04 trial, which was done, which had extended mastectomies and internal mammary lymph node being dissected regularly, it didn't show any survival benefit, and essentially it was abandoned once again. Yeah. So why now? Why now being because PET CT is being routinely done these days, at least in the corporate hospitals. PET CT detects occult internal mammary lymph node disease, which was earlier days was missed. Neoadjuvant therapy reveals discordant nodal response. There's precision radiotherapy and robotic and VATS access to parasternal spaces, which has recently come up. The question is whether internal mammary nodes matter biologically. They clearly do. The question is whether surgery adds value beyond systemic therapy and radiation. So look, just briefly going for the surgical anatomy, just for the students, the internal mammary lymph nodes lie 1 to 3 centimeters lateral to the sternal border in the first to third intercostal spaces, the most common being the second intercostal space. They're embedded in the fatty tissue along internal mammary vessels. The posterior relation being the parietal pleura, and the left side specifically, there is a pericardial proximity. What the AGCC 8th manual exactly quotes is internal mammary lymph nodes are in the intercostal spaces along the edge of sternum in the endothoracic fascia. This is the exact line which I've taken from AGCC. Vascular anatomy, which is critical for us surgeons, is internal mammary artery, which is a branch of subclavian artery. Internal mammary vein, which drains into the brachiocephalic vein. There are perforators to the breast in that area. There is intercostal branches, of course. Common variation being thin-walled internal mammary vessel, internal mammary vein. A duplicate vein, you may have multiple veins in that area, and of course, large perforators to the breast. Technical implication being bleeding control defines safety. In that area, there are multiple vessels, and injury to that vessel may lead to hemothorax, and it is a narrow space in which we are operating. The lymphatic drainage patterns is medial and central tumors demonstrates internal mammary drainage in up to 20 to 35% of the cases. Now, this was published by Umberto Veronesi long back in 1990s based on the sentinel lymph node mapping series. So we cannot clearly ignore it. Internal mammary sentinel nodes identified in 15 to 30% of patients overall. Isolated internal mammary positivity occurs in only 2 to 5% of the cases, even with negative axillas. But it significantly leads to an upstaging. Combined axillary and internal mammary nodal metastasis is associated with higher distant metastasis rates, worse disease-free survival, inferior overall survival. Prognostic significance being internal mammary involvement is an independent adverse prognostic factors, like I mentioned before. Risk of distant recurrences increases when internal mammary basin is involved and often under-recognized without dedicated imaging. So this is clearly a situation which we cannot miss, and it has to be taken into consideration, especially when we have tumors which are in medial and central quadrants. So just quickly going to this clinical staging, we all know what the clinical staging is. The idea is to just see that how prognostically it changes significantly if the internal mammary lymph node is involved. See, if the internal mammary is clinically involved, it directly upstage into a CN2B disease. Be it axillary node positive or not, if the internal mammary node is positive, it directly jumps into a CN2B, and with axillary lymph node is actually a CN3B disease. So we're clearly looking at something which significantly upstages. Important point here to note is metastasis to ipsilateral internal mammary lymph nodes detected by imaging studies, and in that imaging, not just ultrasound but also CT scan is included in the AGCC manual. So a CT scan inclusion is considered into a clinical staging criteria for internal mammary lymph nodes. Pathologically, also, if we look, we all know the staging. It starts with directly PN1B in a sentinel lymph node if evaluated, which is rarely done, sometimes done for a medial and central tumor. PN1C, which includes both axillary internal mammary lymph nodes. PN2B is similar to what CN2B is. And PN3B is essentially even in the sentinel lymph node axillary, in a sentinel lymph node, ipsilateral mammary lymph node, internal mammary lymph node with axillary positivity directly jumps into a N3B disease. So we are clearly looking at something which upstages the disease significantly. This is a level 1 evidence to treat internal mammary lymph node. Now, I'm not talking about surgery, but I'm talking about both surgery and radiation. NSABP B04, which was published in 1970s, compared radical mastectomy versus less extensive surgery, did not show any improved survival of doing an internal mammary lymph node dissection. And from there was a complete abandonment of surgically treating these lymph nodes. ERTC 22922 trial, which is the biggest trial, which included regional nodal irradiation, especially for patients with medial and central tumors and node positive tumors, did show decreased recurrence, decreased breast cancer mortality, and modest increase in overall survival. The Danish breast cancer cooperative group, which is a relatively funny trial because they included node positive patients. They gave radiation to patients who had right-sided breast disease. They did not give radiation to patients who had left-sided breast disease because of cardiac toxicity. And they showed improved overall DFS and OS. I really don't understand how did they get ethical clearance for this. But that's what they've done it. They've treated right-sided breast cancer patients with radiation, left-sided breast cancer patients without radiation, and showed improved DFS and OS in right-sided breast cancer patients because they had radiated the internal mammary lymph nodes. And then we have the Canadian MA20 trial, which is essentially a post-mastectomy radiation therapy, in which they've showed that high-risk node-negative patients and node-positive patients, if we include internal mammary lymph nodes in the RT field, has showed improved DFS. So the gist is no randomized data has support survival benefit of internal mammary dissection. There is strong level 1 evidence supporting regional nodal irradiation, especially in medial and central tumors and node positive tumors. Internal mammary irradiation reduces breast cancer mortality significantly. Internal mammary nodal dissection may be considered only in highly selected cases. Now the question arises, where does surgical intervention come into picture when everywhere the treatment is essentially by radiation? Now I'll tell you some clinical scenarios and rare, but they're MDT driven. Isolated PET avid internal mammary lymph nodes. Rare phenomena only 2 to 5% of the time, especially in luminal A disease. If we see, it is a regional disease. It is not a metastatic disease. A negative axilla is possible. Biopsy may alter staging and may even lead to systematic treatment, which can be escalation and de-escalation both. Persistent internal mammary disease after neoadjuvant chemotherapy, a situation which we sometimes see where axilla and primary has responded completely, but bulky internal mammary node has not responded either completely or not responded at all. In such scenarios, we may consider a surgical intervention and removal of that lymph node. Isolated parasternal recurrences. There's a concept called oligoregional disease. It is not oligometastatic. Patient has been treated before with surgery, with radiation therapy, with on adjuvant treatment or completed adjuvant treatment and developed isolated recurrence in the parasternal area. It is still a oligoregional disease. We can still consider surgery. And special circumstances like RT contraindicated, similar to contraindications of BCS, essentially for RT contraindications like scleroderma, connective tissue disorders, where you cannot treat the patient with RT, you may consider surgery for internal mammary lymph nodes. So IMND is not routine, considered only in highly selected biologically meaningful scenarios with MDT discussion. Now, evidence supporting selective internal mammary nodal surgeries, the series are all retrospective. It is from MD Anderson, isolated parasternal recurrences, R0 resection achievable. 40 to 50% of the patients showed 5 years survival in selected patients. It supports surgery in oligoregional settings. There are other studies like residual internal mammary disease after post-NSCT, published in Annals of Surgical Oncology in 2009. There's role of minimal invasive surgery. Implication being surgery may be reasonable in highly selected or oligoregional cases. This was a retrospective analysis from the Tata Memorial Group, in which they had studied the audit of yield of internal mammary lymph node dissection in literature and review in management of breast cancer. The final conclusion was in inner and central quadrant tumors, internal mammary lymph node is more likely to be involved when ALN burden is high and tumor size is more than 2 centimeters. If the tumor size is less than 2 centimeters, negative axilla, there is a possibility only less than 10%, in which other literature also says that it is around 2 to 5%. A thoracoscopic approach can be explored further for a complete surgical approach in IMNLD. These are few case reports for robotic assisted internal mammary lymph node dissection, which also I will be talking and showing videos in my talk as I go further. So why robotics and VATS internal mammary node dissection? Why is there emphasis on minimal access? The problem with open internal mammary lymph node dissection being internal mammary nodes lies lateral to the sternum within the intercostal space, immediately anterior to the pleura. So there is risk of injury to the pleura in pneumothorax and even hemothorax. Exposure is often tedious and limited, may require additional parasternal incision. It disrupts the cosmesis in breast cancer surgeries and in reconstructions. And it often requires removal of costochondral cartilage. Why robotic? Because it is magnified 3D vision, precise dissection, avoids sternotomy, extended parasternal incisions, improve ergonomics in confined space, and potentially reduce morbidity in expert hands. This is the port position which we use for our robotic patient and port position which we use for our robotic surgeries. If you have to do an internal mammary lymph node dissection, the patient is positioned supine. 15 degrees tilt is given using a bolster. The arm is fixed under the table using the support as shown in the picture. I preferably not avoid doing a hyperabduction as it may lead to neuropraxia at the brachial plexus. It has happened to one of the patients. Port position being arm 2 is the camera arm, which is in the anterior axillary line in the fifth intercostal space. The working ports being arm 1 and arm 3, arm 1 being in mid-clavicular line, 7th intercostal space, where we use a fenestrated bipolar or Maryland. Arm 3 is a working port in the anterior axillary line in the 3rd intercostal space, where we use a monopolar hook. And sometimes a vessel sealer. I'll show you the reason why we use a vessel sealer for such surgeries, why we need a vessel sealer for such surgeries. I personally prefer to use a 5 millimeter assistant port for suctioning. It is triangulated between arm 2 and arm 3 in the mid axillary line in the 4th intercostal space. The anesthesia consideration being single lung ventilation. One point here I would like to make is there is no set template to do an internal mammary lymph node dissection. Even if you read the literature, there is no set template as to how we do an axillary dissection where we have a set template, how we do a retroperitoneal lymph node dissection, how we do an inguinal lymph node dissection, or any other lymph node dissection in the body where we have a set template. Here there is no set template, so it's essentially you remove all the fatty tissue around the internal mammary lymph nodes, internal mammary artery. Sorry. So this is one of the cases, one of the situations which we operated. This was a 53-year-old lady postmenopausal, CT2 lump upper inner quadrant. There was no axillary nodal metastasis. Isolated internal mammary lymph node as shown in the images. It was biopsy was IDC grade 2 luminal B. Patient received neoadjuvant chemotherapy, but it was persistent gross internal mammary lymph node even after a neoadjuvant chemotherapy. MDT discussion was done and we planned for PCS, axillary SLNB, and robotic internal mammary lymph node dissection. This is the video. This is the picture which is seen initially. You take the mediastinal pleural cut and expose the lymph nodes and the adjacent fatty tissue. Along with that, you expose the internal mammary vessel. And then you continue the dissection on the all attempts should be made to preserve the internal mammary vessels whenever possible, as you never know, the patient may end up into a cardiac bypass at a later date, and this internal mammary vessel may be lima or rima may need to be harvested at that time. So all attempts should be made if internal mammary artery and vein can be preserved. Here in this video, I will show you that I'm preserving the internal mammary vessels, but you have to slow meticulous dissection on the undersurface and in and around the internal mammary vessels. As you can see here, this is the internal mammary artery and the vein. This is the vein which is exposed. I'll also show you the artery, and we'll continue to take all fatty tissue on the undersurface of the sternum and on the undersurface of the costochondral cartilage. We have to make sure to do a very slow, meticulous dissection. But a point here to make here is that how easy it is if you have a VATS or a robotic technology, and how easy it is compared to doing this similar procedure with such a big lymph node there if you're attempting a open procedure. So as you can see, and one point again here to note is you don't have to be very aggressive in removing the fatty tissue, as we have to make sure that you are not doing a mediastinal lymph node dissection. It is essentially a internal mammary lymph node dissection which you are doing. A mediastinal lymph node dissection would mean metastatic disease and not regional disease. So here I'll cut open the mediastinal pleura and see along the length of the internal mammary vessel if I see any enlarged lymph nodes or any significant fatty tissue, if it is there. Just small bit of fatty tissue. The specimen actually doesn't come as en bloc. It always comes in bits and pieces because it's just the fatty tissue which you're removing around the vessels. So yeah, and you bag it. Always, whatever specimen is to be come out is to be bagged, either using a glove bag or a proper bag. This was the final specimen. Now, this was the second case. It was a 61-year-old lady, postmenopausal, status post BCS SLMB adjuvant RT for a upper inner tumor. The initial histopath was T2N0 IDC grade 3, luminal A disease. She was disease free for 1.5 years. She was on letrozole. Developed isolated internal mammary lymph nodal recurrence. Very rare situation. It was the oligoregional disease. As you can see in this picture, the lymph nodal mass was very high up. It was not exactly in the second intercostal space. It was actually in the first intercostal space, very close to the subclavian vessels. And here I would see this is a big mass, lymph nodal mass, and all because of the radiation. It is extremely difficult. Initially, I tried doing it with a monopolar hook and a fenestrated bipolar. But as the videos progress, you'll know how difficult it was for me to get planes all around. I can just fast forward this a little bit. 1 second. Yeah. Yeah. So as you can see, it is all post-radiated edematous tissue, and it is getting very difficult to get a plane from the costochondral cartilage and the fat. Here, you can clearly see. 1 second. Yeah. You can clearly see the vessels. Once. Yeah. You can see the vessels. The internal mammary vessels is essentially going inside the lymph nodal mass, and it is extremely difficult. It became difficult for me to continue with a monopolar hook. And I purposely put this video because I want to emphasize the point that we should not shy away from using vessel sealing devices when you are operating such cases, because small amount of bleeding, it is a very high pressure system you're dealing with. Although internal mammary vessel is a relatively small vessel, but it is a direct branch of subclavian, and small bleeding in that area may lead to a catastrophe, and you may end up doing a thoracotomy for that patient. So here, I ended up using a vessel sealing device, and essentially a robotic vessel sealer is a very good instrument. You can actually seal it and just divide the vessel. Here I'm dividing the internal mammary vessel and removing the lymph nodal mass. So this mass was removed in toto. Yeah. So again, this is a third case. Unfortunately, I don't have a video for this, but this was a 63-year-old lady, postmenopausal, status post left modified radical mastectomy, followed by post-mastectomy radiation therapy. She was operated outside, referred to us from outside, not on any hormonal treatment for whatever reasons. She was T3N1 initially, IDC grade 2 luminal A disease. Disease free for 1 year, developed isolated PET positive internal mammary lymph node recurrence. Again, oligoregional disease. We had a MDT discussion and it was planned for surgery. So you can see only one lymph nodal mets. You can see post radiation, all scarred tissue there. And you can see here, I've clipped the internal mammary vessels both and have completely removed this nodal mass. Generally, in the post-operative, we tend to put one ICD after this procedure. It is essentially for the pneumothorax, We remove it on post-operative day 1. Patient is generally discharged on post-operative day 1 after surgery. ICU is generally not required. A total of 9 such cases we have done. No patient had required ICU, and all the patients were discharged on post-operative day 1. So controversial, yes, because historical arguments was there was no randomized overall survival benefit, significant morbidity associated with the procedure. Radiotherapy was effective and less invasive, abandoned after radical mastectomy era. What has changed? Higher resolution PET CT scan, better internal mammary lymph node dissection. Neoadjuvant therapy, nodal response heterogeneity, oligometastatic, oligoregional paradigm, robotic precision in narrow parasternal spaces, reduced rip retraction and vascular trauma. With the central question, if morbidity was the major limitation for internal mammary lymph node dissection, does robotics and VATS technology change the risk-benefit ratio? Question is out in the open. So decision algorithm which we follow at our institute is we look for tumor location which is medial or central. We do a imaging suspicious internal mammary lymph nodes on a PET CT or MRI. Biopsy feasibility, yes, we should always confirm for the biopsy. No, we can do a MDT discussion. Now, if internal mammary is positive either on biopsy or on imaging, we have to look at other scenarios. Like if axilla is positive, definitely the patient is going for a systemic therapy followed by internal mammary radiation. IMND rarely indicated in scenarios like if the primary and axilla has completely responded and the big lymph nodal mass in the internal mammary area has not responded at all or has not shown significant response. If the axilla is negative and there is an isolated internal mammary lymph node mets, which is very less likely, we should consider for tissue confirmation. We should consider surgical excision if RT is contraindicated in such patient. If it persists after a neoadjuvant chemotherapy, it is a solitary oligoregional disease in recurrent cases, and staging will alter systemic therapy, either a escalation or a de-escalation, especially in luminal A disease where we are not planning or we can avoid neoadjuvant chemotherapy or chemotherapy in any form. So take-home points being internal mammary nodal involvement carries independent biological and prognostic significance. Surgical dissection lacks randomized survival benefit. Internal mammary irradiation is supported by level 1 evidence. Selective surgical indications may exist in rare, carefully defined scenarios. Minimal invasive robotic approaches may reduce morbidity in expert centers. Meticulous MDT discussion based patient selection remains paramount. I hope as a surgical oncologist, I was able to justify surgical intervention for internal mammary lymph nodes. Thank you for patient listening, and I'm happy to take any questions. One second. I think I should.
Yeah. Thank you so much, Kushal. Very perfectly summarized and explained the role of internal mammary lymph node dissection. Absolutely agree with you on each and every point. I think the basic points were that it's a MDT-driven procedure. No internal mammary would happen without a MDT discussion. And in fact, the radiation oncologists are very happy if you are willing to take care of a left-sided internal mammary lymph node for them. Second thing is a lot of times mastectomy, you may not even need to put a extra port also for a skin incision. All these ports go through the pectorals major and the chest wall, and the reconstruction and can happen without a single extra incision. I think third part is internal mammary clipping, as you have said and emphasized, that should be avoided as much as possible for a future Lima requirement. And very commonly, plastic surgeons would want you to spare it because sometimes they want to anastomose a flap to a perforator coming out of the internal mammary. So great presentation, Dr. Kaushal. Being a minimal invasive surgeon, what sort of learning curve do you think this procedure has?
I would say you need to be relatively well versed with the anatomy of the thorax. I won't call it very, personally speaking, it is not a very technically challenging procedure when it comes to other thoracoscopic procedures like maybe a lung lobectomy or a segmental resections of lung or even a esophagectomy for that matter. The learning curve, if I have to count in numbers, I think if anybody was...
So we don't have numbers for learning curve, but I absolutely agree with you that people well versed with minimal access surgery in the thorax would find it not very strenuous to do this procedure.
Yeah, because the port position is essentially there's it's a very straightforward port position. The anatomy is well seen in front of your eyes. And I think if anybody is considering an open IMND, you should always take consideration because it will be much more easier when you do minimal access.
Perfect. I think the rest of the points, the questions, the morbidity of the IMLN, Dr. Kushal has said that almost every case gets discharged on day one. The ICD comes out in a few hours or the next day morning. So what raises the suspicion of IM node recurrence in a recurrent setting is the question that somebody has put. So are these all PET detected, or is there anyone who comes with a symptom?
See, essentially, you will not see anybody with symptoms, or if it is truly a very big nodal mass which is sitting on the thoracic inlet, like I showed one of the patients, the tumor was essentially in the thoracic inlet, it was not even in the intercostal areas. So in that situation, you may see patient presenting with some symptoms, but most of the patients, when they are on follow-up and if they've undergone some imaging, either a CT scan or a PET CT scan, which is incidentally detected as as the disease. Uh, you do consider a PET CT scan or a CT scan as a routine uh, follow-up imaging in patients who have had a disease which was initially very advanced stage, either a advanced stage primary disease with heavy nodal burden in the axilla. So as a routine, even yearly basis, you will do a imaging, not just rely on any basic X-rays or sonographies. You will want to do a PET CT scan, and many a times it is such patients who come up with the internal mammary lymph node recurrences.
And we have found that the radiologists have been able to sample these lymph nodes fairly successfully.
It is a tricky area to sample, actually. Uh, I personally believe that if we see a nodal mass, I think surgically tackling it is much easier than actually going ahead with doing a biopsy, because if injury to one vessel may cause a bigger problem at attempting a biopsy and doing, and it's the area where they have to biopsy is technically challenging. It's not that it cannot be done, but to biopsy it, to prove it a PET positive disease, I think as a surgical oncologist, we would want to just go ahead and remove it. See, if there is a tumor, PET positive tumor in the axilla, will treat it with surgery. We'll not do a biopsy to prove it. So why not treat a internal mammary lymph node with surgery? Then why do you have to biopsy and prove it?
Perfect. Perfect. So I think that answers all the questions, Kushal. Thank you so much for your nice presentation.
Thanks a lot.
With this, I think we are come at a close of our webinar today. We thank you all for joining in. On behalf of the IASO academics, we would like to thank all three speakers for their excellent presentations, and all the speakers for all the audience for joining in live. Joining it live always gives you the benefit of interacting with our faculty, which is the best way to attend these webinars. For those who you don't know, we have a YouTube channel. If you just type in IASO webinars, you'll find all our past masterclasses and mastery of surgery webinars there. The previous one on breast cancer, we would also find there. And there are some excellent talks on oncoplasty and sentinel lymph node biopsies, etc. on there. The next month is going to be discussed on cervical cancer. We'll have a masterclass on 10th March about it, and then mastery of surgery on 24th March. Same time, 7 p.m. on a Tuesday. With that in mind, I would like to thank all of you for joining in and wish you a good evening. Thank you.